Hey there, it's Katie, your clinical educator with Beata, and today our education piece is going to be focused on superbugs. So thanks for watching and listening in. I actually have a PowerPoint for the content today, and most of the information we're going to go over today, I actually got from the CDC report that came out with information from like 2019. So the last report that they did on this specific type of infections was done in 2013. So there might be like some comparison, just so you know where a lot of that information is coming from. And as we go through it, we're going to hit on lots of like facts and details. If you're interested in the sources that I got this information from, I did attach most of the links to each of the individual slides. So if you would like a copy of the slideshow, just let me know and I'll be happy to send that over to you. And let me move my stuff up here so I can see better. There we go. Okay, what are superbugs? Oops. Oh no. I don't even know how to go back in a slide, you guys. Control click. No, I didn't like that. Let me just go back to this one. Okay. All right, what are superbugs? So they're also called MDROs, or multi-drug resistant organisms. And this general kind of definition of superbug is a bacterium or fungi that is resistant to clinical antimicrobials. I thought this was interesting because a lot of times we focus a lot on bacteria, but it can be other organisms as well. Antimicrobials, we're going to talk a little bit about antibiotic resistance, as well as resistant to like common antiseptics and things that you would clean stuff with. And based off of the CDC, like we're going to focus on the ones that are pretty significant in our field. Recently, within the last year, we've actually had a couple of superbug infections identified in our patients that were new infections. So we thought it would be good to focus a little education on them specifically. So this slide's asking, why is it important to care about superbugs? Over 2.8 million antibiotic resistant infections occur every year. These are new infections, and it actually causes more than 35,000 people to die every year. C-Diff, which is the one that we've seen in several of our patients over this past year, oftentimes leads to hospitalization and can also have a very high mortality rate associated with it as well. This little detail right down here really terrified me, so I thought I would share it with you guys. I actually became really paranoid after doing all the research on this education. So I don't know if we should be scared or not, but I'm a little scared. It says right now the percentage of clinical isolates of Enterobacteriales, and please don't hold it against me, all of my pronunciation during this video, because some of them are tongue twisters. But this group of bacteria includes things like Salmonella, E. coli. We're going to focus on it a little bit more in a later slide as well, because it includes another really common one I can't think of right now. They're known to be resistant to all antibiotics, around 35%. So if you get an infection, and I mean, everybody, talks about Salmonella and E. coli, E. coli being one of the leading causes of UTIs. You only have a 1 in 3 chance of really being treatable, which is absolutely terrifying to me, especially if it's considered a superbug, which is like, the more scary strain of these kinds of bacteria. The first one that we're going to talk about is MRSA. I did not realize that these were going to pop up one at a time, so hopefully I don't click too far. All right, MRSA is methicillin-resistant Staphylococcus aureus. It is normally colonized in the nose, and about 1/3 of the population. Also colonized back of the throat, can be found in the armpits and skin folds of the body. So it's very naturally occurring in our environment. It is one of the most common causes of wound infections and pneumonia. There is a difference between community-acquired MRSA and hospital-acquired MRSA. Hospitals we know for being like centrals of superbugs, right? Because really the sickest people go there. They're getting treated with lots of antibiotics, and these organisms develop a big resistance to a lot of different kinds of antibiotics. So typically contracting MRSA in the hospital is going to probably have more poor outcomes than you would in the community. Right, don't scratch your wounds. So a lot of times we will swab to test for the MRSA bacteria. If somebody is identified as being either having an active infection or even being colonized with MRSA, well, we need to initiate contact precautions. Contact precautions are going to be your standard precautions, right? Your universal precautions of washing your hands and wearing gloves. And then in addition to that, also wearing a gown, because that MRSA bacteria can attach onto your clothes and stuff. So MRSA survives on towels, razors, furniture, athletic equipment for up to weeks. Resistant to a lot of different strains of antibiotics. And let's see. My only other information is like that person to person is the most common mode of transportation between people. We're going to talk about that too, kind of how these infections get spread and stuff. And typically treated with like vancomycin, linezolid, I said that wrong, and some other antibiotics as well. The next one we're going to talk about is VRE, vancomycin resistant enterococci. Normally found in the human intestine and female genital tract, and naturally occurring in the environment. Again, soil, water, sand. You're going to see that as a common theme, which is why I started getting really paranoid about stuff. VRE is oftentimes seen in urinary tract infections, especially in people that have catheters. Obviously, because that is a direct path for that bacteria to travel up. Also commonly seen in some wound and surgical infections, and can possibly, really any of these infections can go into your bloodstream and cause like full body sepsis. And it looks like it's missing something. Resistance to a whole bunch of antibiotics again. Also requires contact precautions, very similar to MRSA. And this one typically can survive for up to a week on hard surfaces. So with MRSA and VRE, using our standard environmental wipes that we provide the homes with will kill both of these bacteria if used appropriately. And there are instructions on those, you know what I'm talking about, like the canisters that we provide in the home of the wipes. How long the surface has to be like wet for, or how long you have to scrub for in order to actually kill the bacteria. Okay, so now we're on to Acinetobacter baumannii. That one I practiced. Commonly found on the skin and throat, oftentimes causing infections in the lungs, UTIs, and in wounds. Also requires contact precautions. And this one can actually survive up to months on all kinds of surfaces, whether paper, glass, cotton. This one was very like resistant, I found, for temperatures, environments. It just really tends to survive in a lot of settings. So Acinetobacter bacteria is the most common, is a group of bacteria commonly found in the environment, like soil and in water. There are a lot of different types of Acinetobacter, but this baumannii variant accounts for I wrote 80% up on the slide. It counts for 80% of the infections for that specific group of bacteria. And it is the most common infection in humans. So it is resistant to, it says 2 or more of the 5 classes of drugs, including the ones that are listed there on the screen. Oh, then I went too far. Survives weeks to months. We talked about that. And it says outbreaks of Acinetobacter infection typically occur in ICU environments and hospital settings with very ill or disabled patients. It rarely occurs outside of healthcare settings. So this next one is called Pseudomonas Aeruginosa. It lives in water, whether that is fresh or reservoirs. Reservoirs in urban communities can include things like hot tubs, jacuzzis, and swimming pools. Also in soil plants, including fresh fruits and vegetables. Any kind of, oh, this one was actually really scary because, let me read this to you. So it's a commonly an opportunistic pathogen and is an important cause of nosocomial infections like vent-associated pneumonia, catheter-associated UTIs, and others. Reservoirs in hospital settings include where this bacteria is commonly found. Oh, I think I did a typo. Portable water, taps, sinks, toothbrush, ice makers, disinfectant solutions, sanitizers, soap bars, and then of course any sort of like respiratory therapy equipment, endoscopes, and endoscope washers. So this bacteria, I wondered, is the one that they are really concerned about and why they tell us not to like open up the hand sanitizer and then pour it into a bigger hand sanitizer because you can contaminate the sanitizer itself. And the sanitizer isn't necessarily going to kill off this bacteria. It actually like thrives in disinfectant solution sanitizers and soap bars. Blah, right? So this one is commonly found in the GI tract and can colonize in the body as well. We're going to talk about the difference between colonization and active infection. Like I said, it's a bacteria that's the reason for a lot of common infections. Because it's found so commonly in like the water and reservoirs and things, it says it causes an array of community-acquired infections like folliculitis, puncture wounds leading to osteomyelitis, pneumonia, otitis externa, which is an ear infection, and many others. So this one just requires standard precautions, doesn't require that contact precaution of wearing that additional gown. But facilities are required to have water management plans for this specific bacteria because it is so commonly found in all like sources of water and things. Because I was like, man, you can, if it's in your fresh fruits and vegetables and you're not rinsing those off before you eat them, you know, maybe that's why it's very commonly found in the GI tract and can colonize in your respiratory tract. But then if you're washing it in water, are you washing it with contaminated water? I don't want to go down the rabbit hole. It just scares me. Survives up to 16 months on dry surfaces, which is crazy, and resistant to, again, quite a few different strains of antibiotics. C-Diff. C-Diff is the star of the show. C-Diff is the one that's just been hitting us pretty hard lately. So C-Diff is Colostrum difficile, but I'm going to call it C-Diff. Lives very commonly in the intestinal tract. Can also be found soil, air, water. It's in feces because it's in GI tracts, and in food products, of course, because if it's in, the soil and the water and everything, it's going to get into our food as well. This was interesting. So C. diff itself causes diarrhea and colitis, and it's oftentimes brought on by using antibiotics. But it did say that, so like, let's say people who go on antibiotics, a very common side effect of antibiotics is having like GI upset and diarrhea, right? But 15 to 25% of those people who develop that diarrhea is actually C. diff. And after finishing that antibiotic, 20% of those people who were suffering from C. diff will resolve on its own without any antibiotics. So I thought that was kind of interesting. I think a lot of it probably depends on immunodeficiency and like healthiness of your gut, right? So doing things like having GI surgery, being over a certain age, being hospitalized, and things like that are going to put you at a higher risk for developing C. diff. PPIs I thought were really interesting. That's like your proton pump inhibitors. That use of those also increases your chances of developing a C. diff infection, which I was not really sure. Like, if you guys know why that would cause that, let me know. I tried to do a little bit of research. The only thing I could think of was that maybe it changes the acidity of the stomach, and therefore the bacteria that's making its way into the gut. Maybe your stomach kills off some of the C. diff as you're eating it, and then it doesn't like infect you. I don't know. I couldn't really find a good answer on why PPIs increase the occurrence of C. diff. So C. diff is different than the other bacterias that we've gone through already in the way that it is a spore-forming bacteria. So what that means is, and it lives a super long time, right? Is that you cannot just use standard contact precautions on C. diff. Because typically contact precautions, you're wearing that gown, you're wearing your gloves. So when you do your hand hygiene, you can either wash your hands soap and water or use the sanitizer to sanitize your hands, and then you're fine using just like our standard antimicrobial wipes to clean off surfaces and things. C. diff is different because it's a spore-forming bacteria. It actually protects itself in the environment, and you really can only kill it by using bleach. So we do have to use a bleach solution for C. diff when somebody has that infection, and we don't want to use hand sanitizer for the same purpose because it will not kill the bacteria. So you have to wash your hands when you have a C. diff infection and not use hand sanitizer. In the hospital setting, we always called it G contact procedures. I'm not sure if that's something that's commonly used. When I looked it up online, it didn't really look like it. We would call that gastro contact precautions as opposed to just contact precautions. So it's important to know the difference between C. diff versus MRSA, VRE, these other things, and how we protect ourselves against contracting them ourselves or spreading them to others. And then we've got CRE. So CRE are the carbapenem resistant Enterobacteriaceae. And at the beginning of the slideshow where it had that little detail about like, up to 35% are resistant, it's talking about this specific group of bacteria. So very commonly colonized in humans and in animals, excuse me, especially in the GI tract. Includes E. coli, Klebsiella, and Salmonella. Klebsiella pneumonia was the one that I had forgotten the name of at the beginning of this slideshow. So it says Enterobacteriales are a large order of different types of bacteria that commonly cause infection in healthcare settings. They're difficult to treat because they do not respond to commonly prescribed antibiotics. So they're often resistant to multiple classes of antibiotics, and there's 35% of this bacteria class that's resistant to all available antibiotics. Isn't that terrifying? So scary. So if you are hospitalized because this infection becomes severe enough for you and your body's not able to fight it off, it does have up to a 50% mortality because it is so difficult to treat. For the most part, it causes UTIs. And of course, like I said, E. coli, salmonella, these are very common causes of UTIs. Ventilator, acquired pneumonia, and then bloodstream infections, because obviously if you get it into your blood or it just travels into your bloodstream and causes sepsis. And then also abdominal abscesses or any sort of open abdominal wounds. Requires your contact precautions, so wearing a gown in addition to your gloves. Oh, and I clicked again too much. Let's see. So the other thing that was interesting about these CRE group is that it looks like they really took off after 2001. So we're talking about a fairly recent bacteria that's like been able to mutate and evolve and become resistant to all of our antibiotics and things. So it's just scary because it's like newer too. Those who are at greatest risk. Oh, where's my clicker here? Oh, it's not going to tell us who's at greatest risk. I'm not sure why. So those at greatest risk are going to be typically people who are immunocompromised. So we see those as people who are, have other like comorbidities or diagnosis in health, or who have an acute illness and find themselves being hospitalized in healthcare settings. People who tend to be having weaker immune systems. So we look at, the older population or those that are younger, and I'm trying to think if there's anything else kind of obvious there. Oh, here we go. Recent surgery. Okay. So obviously if you've had recent surgery and you've got lots of potential for infection in addition to kind of a weakened immune system. Again, if you've been in facilities where these superbugs are hanging around, any kind of hospitalizations, especially if you find yourself in the intensive care unit or on a ventilator, it opens you up to a lot more risk for infection. Immunocompromised, indwelling medical devices. Again, things like urinary catheters have such a high incidence of infection with them. That's why hospitals are super intense about like discontinuing catheters ASAP. And we have to be really, really careful about central line devices and making sure we're using sterile technique. Same thing with wounds. We want to be really cleanly when we're changing out wound dressings and those kinds of things. All right, infection versus colonization. And can the infection go away on its own? So there is a difference between these two. Colonization means that the bacteria is present and that in the body typically, and that it is growing, and it's more likely to cause an infection because it is already present and it's already reproducing. Whereas an actual active infection, we all know what the signs and symptoms of infection are. We, whether that be pain, fever, swelling, redness, warmness to touch, so on and so forth. If you advance into something like a septic infection, then you're dealing with more systemic presentation of infection where they're going to have low blood pressure, high heart rate, confusion, all of those things as well. It does say that clients who are colonized or infected are both going to be carriers of that bacteria and can transmit them to others. So again, the scary part of that is being colonized with something, and like the MRSA slide said, 1 out of 3 people are colonized with MRSA in their nose. So being a nose picker and then going and touching other things or other people can absolutely spread that bacteria to them. And it may not make them sick right away, but if anything should happen where they get sick or they find themselves in need of surgery or in the hospital, can actually become very active and take over and make them very ill. And so a lot of hospital programs even will swab for those things upon admission, and they'll go ahead and treat it. Even if it's not an active infection, if they're colonized with it, they will still treat it just so that it doesn't cause a more drastic infection, you know? So you might see that very commonly in somebody who's scheduled for like a surgery or something. Maybe they're going to go ahead and do some testing on them and make sure that they're not colonized with one of these infections. Modes of transportation. So the most common vehicle of MDRO transmission in healthcare settings are on our hands, which is why, you know, they hit us till we're like numb in the head with hand hygiene. So hand hygiene, of course, is going to include washing your hands with soap or water and then using our hand sanitizer. For BIATA's policy at this point in time, any hand sanitizer over 60% is acceptable to use and should kill the bacteria. And then when you're washing your hands, you do want to use our antimicrobial soap because you're not often going to find like an over-the-counter antimicrobial soap. You might find an antibacterial, but it's not going to kill those other organisms like our special ordered in stuff does. So make sure you're using our soap when you're washing your hands in the home. Wash your hands for 20 seconds under warm water. And then, of course, we're drying our hands with paper towels, not towels hanging in the home, because we've learned we do have bacteria that loves to hang out on things like towels for weeks and weeks at a time, right? Which one was it? I was going to try to find... which was the one that said that it loves to hang out on towels and razors and stuff? I don't know. It's probably the Acinetobacter one. Whoa. Okay. So, and it's these bacteria love to hang out on environmental surfaces and therefore are oftentimes carried on patient care equipment. A lot of times what they're talking about with patient care equipment is going to be your stethoscope that you're taking from one patient to another, the pen that you're using to write everything down, your clipboard. If you're using a blood pressure cuff on more than one patient and you're not cleaning them in between people, all those kinds of things. In the hospital setting, we always have like the nurse on a stick, you know, that the tech usually goes around and does vitals with. And you'll oftentimes see, like, if a patient is in an isolation room, that they might have a nurse on a stick dedicated just specifically to them during their stay, so that we're not taking it room to room. Or at least those were common practices when I worked in the hospital, but it's been a while. Let's see. So other modes of transportation are going to include any contact with contaminated skin, body fluids, equipment, and environmental surfaces. And when cleaning and disinfecting, focus on surfaces that frequently contact people's bare skin, like desks, chairs, benches, gym equipment, lockers, faucets, light switches, and remote controls. In particular, clean any surfaces that can come into contact with any uncovered wounds, cuts, or boils. So that's why we always want to say if you got an open wound, we want to cover it, especially because other bacteria could float on over into it. And then in addition to cleaning surfaces, doing frequent hand cleaning and keeping wounds covered can keep bacteria from either spreading, you know, to or from. So the CDC had developed a campaign back in 2013, probably even earlier than that, but I was reading about the one that they did in 2013, to really prevent and reduce antimicrobial resistance in healthcare settings. And the 4 strategies that they came up with focus on preventing infection, accurately diagnosing and promptly treating infections, prudent antimicrobial use, and preventing transmission. I feel like preventing infection and preventing transmission have a little bit of an overlap. And I think, a big part of the campaign to prevent and reduce this resistant organisms is the education focus on it and making sure people are actually aware, right, of what infections are out there, all the stuff we've covered in these slides today. So it says generally clinicians should avoid prescribing antibiotics unless absolutely necessary. Not only are there other things associated with prescribing unnecessary medication like costs, but by not prescribing antibiotics unless they're needed, we prevent the emergence of resistant strains of bacteria, which is the case with all of these multi-drug resistant organisms. It says targeted infection control practices aiming at the prevention of pseudomonal infections, especially in the hospital setting, are becoming increasingly important. Analysis of various mechanisms of antibiotic resistance is also going to be beneficial long-term in determining the epidemiology and improving infection control. So one of the interesting things is these bacteria don't all become resistant in the same fashion, if that makes sense. Kind of like how C-Diff is a spore forming bacteria, so it actually like makes a little like capsule around itself and protects itself from environmental things that would damage it. Not all organisms do that in order to become resistant to an antibiotic or to antimicrobials. So studying that and figuring out how that bacteria is doing it is one of the ways that we can then try to tackle like reducing the resistance to antimicrobials, if that makes sense. And then these people just look really happy because I feel like this is kind of a depressing, like downer topic and might scare you a little bit. And so you have the power to prevent, to try to control the transmission of, and to educate others when we're talking about MDROs. So it's in your hands. Alrighty. And that's it. That's all I have for you today. If you have any questions, just let me know. And again, if you would like the copy of the slideshow, just let me know. And please, if you find any additional information on your own, I would love to dive into it even more. There's so much to cover with this topic. It was really hard to like narrow it down. So there's a lot of avenues we could go into, especially if you guys are interested in learning more about the clinical symptoms of these infections and like how to identify them. We can talk about that some more as well. So let me know what you think. Thanks for tuning in. Bye.